We will be talking about metabolomics as usual, and today our topic is going to be medications. Now, the big question is how many people work with meds in practice? Because it's probably the most well-studied field, especially when it comes to metabolomics, just because more money, more funding goes into looking at diagnostics and testing and dosing for different pharmaceutical medications compared to something like a supplement. There's a lot of metabolic information for dietary stuff, but the area of pharmaceutical sciences is just more well studied. And so we got a lot of good stuff to cover. So we'll begin sharing my screen. Okay. Welcome, everyone. We will be talking about medication considerations and metabolomics. And so, as I mentioned, I'm Dr. Greg Nacarelli. I am a naturopathic doctor and a PhD in genetics and genomics. I'm a precision health consultant and clinical success manager at Thyroid. And my goal is to combine natural medicine with omics technologies, ultimately to improve precision and personalization of medicine, which is sorely needed in this day and age. And so with that said, we will be talking about medications today. We'll be looking at how they're relevant to metabolomics, covering some foundational information about medications, some pharmacokinetics, pharmacodynamics, pharmacogenomics, and then pharmacometabolomics. And then ultimately looking at so there's lots of medications out there, and I wanted to highlight just some of the most commonly prescribed medications in the United States and look at some relevant information for them as it pertains to metabolomics. And so looking at the current landscape, the most commonly used pharmaceutical drugs are only effective in 25 to 60% of patients. There's a large disparity in terms of what works and what doesn't. And this is pretty well studied. It varies based on the drug class. And so, for example, if you look at hematology medications, they're successful roughly 26% of the time. Allergy medications are successful around 14.7% of the time. And then you have things like cardiovascular medications, successful 6.6% of the time. Again, this is for the medication that it is being prescribed for the disease. Is it effective in preventing the disease or the event or whatever it is? Oncology, absolutely the worst, especially chemotherapeutics, highly unsuccessful, 5% success rate. That's atrocious. So there's a lot of need for improvement in drug medications. There's lots of reasons behind this, but the low success rate stands nonetheless. Not only are drugs not successful, there's lots of drug reactions. So 2 million adverse drug reactions are reported in the hospital each year. This is so many people just had a reaction. They didn't even go to the hospital. And each year, 100,000 fatalities are caused by adverse drug reactions. So another aspect of pharmaceutical medicine needs to improve. How many Americans are taking pharmaceutical agents? So basically, it's a coin flip. Roughly 50% are taking a medication, and roughly 25% of Americans are taking 3 or more medications. So it's not uncommon. Within pharmaceutical sciences, there's a couple areas to consider. So there is pharmacokinetics, and this is considered what the body does to the drug. And so things that impact pharmacokinetics is the absorption, the drug interactions, how it's eliminated, how it's metabolized. And then there's pharmacodynamics, and this is what the drug does to the body. And this is going to affect several different things, someone's tolerance, their drug receptor status, and genetic factors, and drug interactions. And then there's pharmacogenomics. Now we're getting into the omics field. This is the study of how someone's genetic inheritance affects individual drug responses. So basically, how do our genetics impact what the body does to a drug and what the drug does to the body? There are lots of different genes that have been studied for assessing pharmacodynamic and pharmacokinetic responses to drug medications. When you're looking at these, oftentimes they're within these CYPs, which I'll discuss in a little bit. These will do extensive drug metabolization. And so you could look at specific medications, and you could look at what gene is coding for what protein that metabolizes it. And then you could look at specific SNPs within this gene and how they may be impacting the metabolism of this. Not just how they're metabolized, but here's receptors. Adrenergic receptor beta 2, adrenergic receptor beta 1 will impact how these medications, which act on these receptors, will respond. MTHFR impacts methotrexate response, VCORCs. See, this will impact warfarin response, statins, HMG-CoA reductase. So there's lots of genes, lots of information that is associated with this. And, based upon this information, maybe you want to choose a different medication. Maybe you want to increase the dose because you metabolize it very quickly. Maybe you want to decrease the dose because you have slow metabolism of it. In some cases, like this one, HLA B5701, there's something called Stevens-Johnson syndrome where people's skin begins to melt off because they have a horrible reaction to a drug medication. So, in some circumstances, this could be life-saving, knowing this information. So, and there is a big push for pharmacogenomic testing to be more readily available in all clinics and just nationwide for insurance to cover it, because again, it's the difference between increasing drug response, decreasing adverse events, which again is sorely needed. When you take a drug, what's going on, especially when it's metabolized? Like I mentioned, phase one drug metabolism is with these cytochrome P450 enzymes in our liver and in our small intestines. That's phase one metabolism. And then they undergo phase two, which I'll cover in a second. These drugs are then conjugated to something, sulfur group, glucuronic acid, a glutathione, cysteine, and then it's then excreted from the body. Yeah, if there are impairments in either step of this process, you can get an accumulation of these reactive intermediates, which is not good. This is where, I feel like there's a push in conventional medicine to say detox doesn't exist. And I think it's the silliest thing because, like, how can you say that? Like I understand, okay, some detox supplements or things that are recommended are overstated in their ability to affect health outcomes. But to sit there and say like detox is a myth, it's like it doesn't make sense. I don't know how they could say that. So because it absolutely happens. So there's phase one, there's phase two. Phase one, we have our cytochrome P450 enzymes. These will do oxidation of compounds, reduction of compounds, hydrolysis, hydration, and dehalimate. Lots of nutrients are involved in this process. Some B vitamins, glutathione is actually used in this process, some amino acids, and we have superoxide radicals that are formed sometimes from this process. This is where having sufficient antioxidants in your diet and other bioflavonoids can help protect from the reactive oxygen intermediates that are formed from this process. And then there's phase two conjugation pathways. This is where a moiety is attached to the intermediate that is formed. Lots of them can occur: sulfur, glucuronidation, glutathione, acetylation, amino acid conjugation, even methylation. Ultimately, we want to take these lipid-soluble compounds and make them more water-soluble or polar. This way we could get rid of them, either in the stool, via bile, or in the serum, then out the kidneys through the urine. So we ultimately want to get rid of these. And this doesn't just happen to drugs. This happens to everything. This happens to our own toxins that are formed in our body, nitrogen compounds, mycotoxins, other environmental pollutants, toxicants and toxins. So whether they're man-made or come from their environment, our body's trying to detox and get rid of it. When looking at drug detox enzymes, CYP450 enzymes are the overwhelming majority performing drug detox, roughly 73% of them, or 73% of drug detox is from these enzymes. UDP glucuronosol transferase, 15%, esterases, flavin monooxygenases, 1%, and acetyltransferase. There's actually some risk variance in this gene where it's associated with cancer. So even though it's 1%, if you impact this, it could have a pretty significant impact. And then monoamine oxidase, only 1%. So CYP is largely responsible for drug metabolism. Roughly 80% of all phase one enzymes. There are 18 different families of CYPs. Only 4 will play a role in drug metabolism. CYP 1, 2, 3, and 4. And so the rest are doing a bunch of other things. CYP A4-5 is responsible for 30% of drug metabolism. CYP2D6 responsible for 20%. And as I mentioned, they are expressed in the liver and the small intestines. So what are these other CYPs doing? They're metabolizing other things. We have, so they won't just metabolize drugs. Remember, our liver formed before drugs even came into existence. So the drugs happen to be metabolized through certain SNPs. But CYP4 will metabolize arachidonic acid, fatty acids. CYP5, thromboxanes associated with inflammation. CYP steroid biosynthesis. CYP19 is aromatase. Everyone talks about aromatase. It's actually a CYP. CYP24, vitamin D reactivation. CYP26, retinoic acid, vitamin A. And so CYPs are important and they play a large role in detoxing various things. So then the question is, okay, if someone's on a medication, people don't just do meds. They also consume fluids and they eat foods. And so how are those things impacting their detox? And so this is something else to account for. So for example, caffeine in coffee and tea and energy drinks is an inhibitor of CYP1A2. And so, well, it's a substrate, but also a slight inhibitor. So if someone's having a lot of caffeine, it could be affecting drugs that are also metabolized through this enzyme. Bioflavonoids, theaflavins, and flavonoids are inducers. That means they upregulate the expression or activity of CYP1821. Transverse resveratrol, gallic acid from red wine inhibits CYP3A. Beer, isoxanthumanol, CYP4 inhibitor. That's a big one, right? So imagine if you take 30% of medications are metabolized through CYP3A4. Imagine if someone's consuming alcohol. They're going to be increasing their drug levels. Cruciferous vegetables. This is why they say they promote detox. How are they promoting detox? Compounds in the cruciferous vegetables, indole 3-carbinol, and the isothiocyanates are upregulators of CYP1 and CYP2 enzymes. And when they do that, they're helping them to detox many different things. So there's that. Parsley, thyme, celery, apigenin, which is found in there, are inhibitors of certain detox enzymes. Legumes, dietazine inhibitors of CYP1, CYP1B1, and then CYP3A4. So just something else to consider when you're looking at pharmacogenomics and then how our diet is impacting detox. And ultimately, these are going to be affecting metabolic pathways. But if you think of detox as a metabolic pathway, it's affecting our metabolism. So when working with medications and metabolomics, it's more likely than not that someone's going to be on a medication. And so when you're seeing somebody and you've run their metabolomic information, typically they're on something. And so there's going to be some impact of the medication on the metabolome. It will likely have some interaction with supplements they're taking. And also another thing to consider is how all of that is affecting their symptoms. And so in order to answer these questions, we need to have knowledge of what is the mechanism of the medication? What is it being indicated for? Why were they prescribed it? What are the possible side effects of it? What possible nutrient depletions can occur being on that medication? And how is it impacting metabolite pathways by looking in shifts in the metabolites? One thing to ask the patient is, how has their response to their medication been? How long does their doctor want them to stay on said medication? And is there a plan for them to get off of it eventually? Anytime someone is prescribed new medication, that's a question I always ask. Frequently, people are put on medications with no plan, right? If they're on a GERD medication, am I going to be on this the rest of my life? If they're on a thyroid medication, am I going to be on this the rest of my life? What is the plan for someone to go on a medication? This is something external to the body. And even if that is the case, that conversation should be had, because otherwise people will wind up being on a medication, then they'll have more medications being added, and they add up, and they don't know why we're on some medications, and the medications will start interacting with each other. I have some people on anti-dopaminergic medications, and then they're on dopaminergic medications and serotonin inhibitors and serotonin reuptake inhibitors, and they're on these uppers and downers, and it gets very confusing. So, and that's unfortunately what happens in a conventional medical setting is it's just not being tracked well. So that's one thing I always try to establish with patients is get some background information with that, or have them go back to their doctor and ask those questions. That is different from making sure their diet is giving them what they need for foundational health. And then if they're supplementing with something to help get what they're not getting. So for example, if they are not getting enough methylated folate in their diet, they could supplement with it to get enough. There should be plans for all of that. There should be a dietary plan and there should be a supplementing plan. And those are different because we are trying to get something so the body has sufficiency versus medications. There's not, you're not giving a medication because there's some insufficiency. No one has an antibiotic deficiency. No one has an HMG-CoA reductase deficiency. So, there's a difference in philosophy there. Consider the scope of practice. So if you're prescribing, deprescribing, or adjusting medications, make sure it is within your scope of practice. Discussing health information, health risk is generally within most people's scope of practice. So you're allowed to talk about it. Addressing alterations in metabolic pathways from nutritional perspective should be within scope, assuming nutrition is within your scope of practice. If it's not, again, just merely having that conversation as a consultant should be okay. Just make sure you have had your clients sign waivers addressing that you are acting as a consultant in that role and not diagnosing or treating. Consider collaborating with prescribing physicians. I have these conversations all the time. Why is so-and-so on this medication? What's the plan? If somebody's on a certain medication, especially if medication is causative for health concerns, I can't tell you how many times someone has come and the main reason they're seeing me is they have nausea. And I look at their medication history and they're on 12 meds. And 6 of the meds, the side effect profile is nausea. And I asked them, how long have they been nauseous? They're like, well, the last 6 months. And they've been on these meds for like 8 months. And I'm like, look, I don't think this is some like rare genetic thing. I don't necessarily think it's something in your diet. It's probably medications. And so I have them go back to their physician and say, hey, I think some of the medications you're on are making me feel ill. We have to educate practitioners that they need to give that feedback back to their physician to let them know. So the physician either adjusts the medication or adjusts the dose because it could literally be the cause of their illness, their current most pressing illness. All right. With that said, let's talk about pharmacometabolomics. So pharmaceuticals, metabolomics, looking at the metabolome. This is basically the study of the effects of drugs on a biological system by looking at changes in metabolic pathways, metabolite levels. This could be investigated before, during, or after drug administration. The effects are going to vary widely based on the mechanism of action of the drug, the therapeutic index, duration, somebody is on a medication, their genetic predispositions. Lots of different factors can impact that. But basically, all of our complex diseases, whether it's obesity, diabetes, cardiovascular disease, all of these, we could look at how shifts in the metabolome are occurring based on these medications, and we could see how is it affecting their diagnosis, their prognosis, and is it ultimately moving the needle for their health states. This is a newer field. Most studies, if you look at them, there's a couple of human studies, but most of them are done on cells or rats and mice. So it's a newer field. But this is looking at shifts in metabolic pathways from being on pharmaceutical agents. And so, for example, the chemotherapeutic agent cisplatin, you will see shifts in cysteine, 3-hydroxybutyrate. This is a oxidative stress marker. Cysteine is a detox marker. And you're going to see changes in taurine, hypotaurine metabolism, phenolene metabolism, and TCA cycle. This doesn't surprise me because the body's probably trying to get rid of this toxic compound. So some of it is intuitive in that regard. Lidocaine, which is interesting. You'll see changes in pentose phosphate metabolism, TCA cycle, amino acid antioxidant metabolism. Again, body's probably trying to get rid of it. Vancomycin and antibiotic, 4-hydroxyproline, which is interesting, associated with collagen synthesis. Dexahexanoic acid, that's DHA, serine. So you'll see changes in glutathione metabolism, glyoxylate, and dicarboxylate metabolism. So you could theoretically see shifts in these, though, again, commercially available pharmacometabolomic tests aren't available. We kind of have to infer that information from currently available metabolomic tests. And so what about the most commonly prescribed drugs people are on? And so these are literally the top 10 in the United States. Torvastatin, 110 million prescriptions per year. Thyroxine for hypothyroidism, 103 million. We have metformin, lisinopril, amlodipine, metoprolol, albuterol, losartan, omeprazole, and gabapentin. So I'll be going through these. So torvastatin. This is an HMG-CoA reductase inhibitor. We look at the process of making cholesterol, which is not listed. It goes down here further. Oh, here it is. So if we inhibit HMG-CoA reductase, we're inhibiting the production of this thing, mevalonate, which ultimately will make cholesterol. And so in theory, it decreases our cholesterol production from our liver. This drug is indicated for hypolipidemia and hypertriglyceridemia. Side effect profile, myocystitis, mitochondrial disruption, elevated liver function tests, ALT, AST, cognitive impairments, lethargy, elevated blood sugar, some not so good things. When it comes to nutrient depletions, so if you look here, what is also needed or what is also made from mevalonate is farnesyl and geranol. And these things will make important things for our cells. Prenylated proteins helps with membrane stability, signal transduction. Dolichols helps with protein glycosylation, cell growth, and differentiation. And then ubiquinone, CoQ10, helps with mitochondrial health, mitochondrial respiration, apoptosis. And so if you block this, you're going to get lower amounts of these. And so we will be deficient in these. And you can actually supplement with these CoQ10, geranol. Also, you could be depleted in vitamin D, vitamin E, beta carotene. They did a study where they looked at, put somebody on a statin, measured CoQ10 levels after 30 days being on a statin, and there was a 50% decrease in CoQ10 levels. Pretty profound. Drug-herb interaction, St. John's wort will decrease the drug levels because it's an inducer of CYP3A4. Turmeric, green tea, and grapefruit will increase drug levels because it's an inhibitor of CYP3A4. So it's another thing to consider. Someone goes on a statin, they're also drinking grapefruit juice, they're increasing that dose of statin. Metabolic pathways that are impacted from this. And so you're going to see impacted lipid metabolism pathways, mitochondrial pathways, obviously, when you're affecting CoQ10, and glucose metabolism. And yeah, it's actually profoundly affects a lot of parts of metabolism. So yeah, it's a powerful drug. There are lots of natural HMG-CoA reductase inhibitors available. The difference is they are nowhere near as powerful as a statin. And usually there's some other added benefit or mechanism that they're acting to lower cholesterol than just inhibiting HMG-CoA reductase. And the side effect profile for these is a lot better than statins. Black cumin seed oil, one of my favorites, just numerous different benefits. Citrus bergamot, aged black garlic, berberine, another favorite of mine. I lowered my cholesterol. Actually, I was measuring ApoB. It was like 127 or something, 130 something, which is not good. A lot of people say your ApoB should be around 90. I went on black cumin seed oil, citrus bergamot, and berberine for a couple months, and I lowered it to 80 with just adding these, no other changes in my diet and lifestyle. So they work pretty well, at least just for me. But also, according to studies, they work well. I should say red rice yeast. As I mentioned in a previous webinar, the active compound monocolin K is not found in red yeast rice products in the United States. They don't allow it. So I don't recommend red rice yeast. Also, it's from a fungus. Some people don't react well to those. Milk thistle, cinnamon, ginger. This was a new one that just came out. So I'm not even going to try to pronounce this. Spid A from Schisandra, which is one of my favorite herbs. It's a bitter. It's good for detox. It's very pungent. When you take it, it's a powerful herb. But it's recently shown to be help lower cholesterol through this impact on HMG-CoA reductase, which is very interesting. So add Schisandra to the list of potential natural HMG-CoA reductase inhibitors. Metformin. This works by transiently inhibiting complex 1 of oxidative phosphorylation. This will alter the AMP, adenosine monophosphate, to ATP ratio, thus activating AMPK kinase. Lots of metabolic changes will happen on this. You're going to see decrease in gluconeogenesis, increase in fatty acid oxidation, increase in glucose uptake, increased fatty acid oxidation, decrease in adipogenesis, decrease in muscle inflammation. Lots of good things, actually. This is one of the more favorable drugs. One of the issues with this is you will get reduced B12 absorption in the terminal ileum, so people could be B12 deficient. And also, not that it depletes CoQ10, but in studies where they have paired it with metformin, there's been better outcomes. So this drug's typically recommended for anything in the metabolic syndrome umbrella. Drug interactions, really the main thing you want to worry about here is if you're on other glucose-lowering supplements that could potentiate the impact of metformin on these pathways. Also, actually with all of these medications, be careful if you're taking any binders or fibers that could decrease the absorption or slow the absorption. Psyllium husk, guar gum, charcoal especially. The big one here is the AMPK or the AMPK pathway. And so AMPK kinase is going to be activated by taking metformin by inhibiting complex 1. And this will result in lots of different things. So PGC1 alpha is needed for mitochondrial biogenesis, making more mitochondria. You'll see SIRT3 upregulated for mitochondrial protection. Your glucose transporters, GLUT4, is going to be translocated to the cellular membrane so we could take more glucose into the cell. SIRT1 and 2 are going to be activated. Autophagy is going to be activated. So lots of different molecular pathways associated with anti-aging benefits are activated by activating AMPK kinase. You know, if there was only something natural we could do to activate this process, there is. So there's lots of different ways to naturally activate AMPK. Well, this is sensing how much ATP we have in our environment. So fasting itself would be activating this, and also caloric restriction, just longevity sensing or longevity strategies, but also compounds can activate this as well, either directly or indirectly. And so there's lots of them here. Resveratrol through SIRT1 can activate this. Berberine through activation on activating the respiratory chain can impact this. Polyphenols, quercetin, alpha-lipoic acid, EGCGs through calcium calmodulin binding protein, even polyunsaturated fatty acids. So, and this is where, you know, these don't have to necessarily be supplements. I mean, berberine you can get from a berry, barberry. Genistein from soy. Apigenin you could get from, I believe onions is a high source. Oh, no, excuse me. That's quercetin is the highest source of quercetin. And cleavers are another one. Resveratrol from grapes, EGCG from green tea. So foods and or supplements can potentially activate AMPK. Lisinopril. This is an angiotensin converting enzyme inhibitor, and this is indicated for hypertension. Some of the side effects for this: dry cough, dizziness, lightheadedness, hyperkalemia. Potential thing to watch out for that, rash and GI symptoms. In general, ACE inhibitors can be associated with lowered potassium, magnesium, folic acid, and zinc levels. Drug-herb interactions. You want to be careful with charcoal, which could decrease the absorption. Tyramines, which is found in aged meats and cheese. This can actually increase hypertension, so you want to be careful with that. It's going to reduce the effectiveness of this medication. Metabolite pathways. And so one big one is the bradykinin pathway. Specific metabolites within the bradykinin pathway is this DesArg9 bradykinin. And so by inhibiting ACE, we're going to inhibit the degradation of bradykinin, which it's kind of a double-edged sword because by inhibiting angiotensin 2, we are blocking nitric oxide, but then by inhibiting bradykinin, we're increasing it. So there's kind of this dual-edged thing that's happening with being on an ACE inhibitor. And so there was a study actually, as I mentioned, 25% of all Americans are on 3 or more medications. And usually, let's say somebody, they just don't have access to this information. They go to the conventional doctor who never got this access to this information in general about diet and lifestyle. And the way to treat things is through medications. It's very common. Someone will be put on a beta blocker to decrease their blood pressure, put on an ACE inhibitor to decrease their blood pressure, and then for their high cholesterol, put on fibrates and put on statins. So this is actually pretty darn common. There was a study that looked at what happens when people are on all these medications, right? And so they actually looked at changes in metabolism from these. And what they found being on these 4 medications, pyroglutamine was altered. And so you're on medications, your body's going to try to detox them. So that makes sense. Detox glutathione metabolism was altered. Our catecholamine pathways, this phenylalanine, phenylalanine, 2-phenylalanines, this precursor for tyrosine. So you're going to say catecholamine metabolism altered. Makes sense because we're blocking beta adrenergic receptors. Pseudouridine altered, associated with RNA metabolism, markers of lipid metabolism altered. And then this one, 2-hydroxyisobutyrate, associated with oxidative stress, environmental pollutant exposure, breakdown product of fibrates. So this is also elevated. So you'll see changes in the metabolome being on multiple medications. Natural ACE inhibitors. This is one of my favorite ones. I feel like this is the one where there are so many herbs and natural products that will affect ACE. And this is where if somebody has these foods in their diet, they're going to naturally have lower blood pressure. You could look at the individual herbs, allium, garlic, onions, capsicum, annuum, red peppers, curcumin, turmeric, ginkgo, hibiscus, one of my favorite ways to lower blood pressure, jasmine, mentha, it's peppermint, moringa. I don't know why mucuna is there. Mucuna is dopaminergic. I would not give that for blood pressure. Don't give mucuna. When I was in naturopathic school, we were messing around with herbs and I was trying bulk herbs at the time. And I did a couple tablespoons of just pure mucuna and there's dopamine or L-dopa in mucuna. And, yeah, I was sitting in clinic and I felt like I was having a panic attack. I'm like, what's going on? My blood pressure, every time it's been measured, it was usually like 110, 120, pretty normal. They measured my blood pressure and it was like 180 over something. And the doctor on staff was like, what the hell is going on? But I'm like, must have been those herbs I took. So, yeah, I would not give mucuna. Now, if somebody has low blood pressure or symptoms of low dopamine, I would consider mucuna. But also, when you mess around with dopaminergics, there's this kind of seesaw effect. So mucuna is one of those herbs I'm pretty cautious about. Osmanthus sanctum, holy basil, oregano, parsley. So lots of different herbs, so lots of herbs and spices that you could use to act as natural ACE inhibitors. Here's berberine, epicatechin, polyphenols, ferulic acid. Anyone recognize this from the Aristotle? We test for a lot of these molecules. So anyway, lots of different ACE inhibitors. Metoprolol, this is a beta-1 adrenergic receptor antagonist. This is used for hypertension, heart failure, arrhythmias. Some of the side effects of this, by doing that, you can have hypotension, bradycardia, or slowed heart rate, arrhythmias, cold hands and feet, potentially GI issues, erectile dysfunction, depression, nutrient depletion associated with metoprolol, CoQ10. Drug-herb interactions, so astragalus, which I love, astragaloside 4 has been shown to increase telomere length. It's metabolized by CYP2D6. So is metoprolol. And so what happens is if you take astragalus, you're going to decrease the absorption or the metabolism of this. You're going to increase the drug concentration. So that's something to be aware of. Snake root as well, increased risk of bradycardia. This is probably the most powerful herb in the natural medicine space to lower blood pressure. I think it's so powerful. It could result in these same side effects. It's really strong. So I would not give any snake root. There's usually other better things to lower blood pressure, to be honest with you, but Metabolite pathway. So you'll see serotonin and fatty acid metabolism alterations with metoprolol, as was mentioned on this slide. So, okay, natural beta blockers. So this was actually from, I believe it's from China. So a lot of the herbs that they include on here are Chinese, but a couple stood out to me. So if you look at pure compounds, beta adrenergic receptor inhibitors, this one, Nulumbo nucifera, is what we call lotus. This is actually a natural beta blocker. And then Pimpinella anisium, which is my favorite Latin herb to say, is anise, natural beta blockers. Albuterol, this is a beta 2 adrenergic receptor antagonist, or excuse me, agonist. In activating this, it's going to have a profound impact on metabolic pathways. You're going to see enhanced glycogenolysis and gluconeogenesis, which results in higher glucose loads, enhancing glycolysis, increasing pyruvate production, which can also increase lactate. You're also going to get lipolysis, which is going to increase free fatty acid levels, which will result in acetyl-CoA entering the Krebs cycle. So lots of metabolic changes actually on albuterol. Side effects, because this is activating the beta-2 adrenergic receptor, tachycardia, chest pains, headaches, anxiety, dizziness, shortness of breath. No known nutrient depletions on this. Interactions, anything else that's stimulating, black tea, caffeine, cocoa, coffee, guarana, which will increase the inotropic effects of these beta agonists. Levothyroxine, this is a thyroid hormone before. The idea is that our body will convert this to T3 as we need it. T3 is the hormone effector in our body. Indicated for hypothyroidism, side effects, hyperthyroid, diarrhea, headache, weight loss, sweating, heat intolerance. Nutrient depletions, non-associated with this. Drug-herb interactions. So if you're giving thyroid medications, or if somebody has low thyroid in general, even if they're not on levo, carnitine and alpha-lipoic acid may decrease the effects. So be careful with that. When we're talking about thyroid hormone, basically all metabolic pathways are going to be altered. Energy homeostasis and skeletal muscle and adipose tissue, in our hearts, liver, basically every organ system is going to be altered by increasing the metabolic rate. So increased glucose metabolism, increased fatty acid metabolism. And so, yep, lots of different effects from there. One thing to consider, nothing out of all these medications, nothing bothers me more than thyroid hormone, because when somebody is hypothyroid, the question is what is going on that their body cannot make enough thyroid hormone for them to use? And even how do you even assess that that's even occurring? Measuring TSH is not sufficient in and of itself. People get put on a thyroid medication for the rest of their life. No one cares to answer that question. But the same nutrient deficiencies that are resulting in hypothyroidism will have other impacts on the body, because they could potentially have low iron, which helps with thyroid peroxidase. They could have low glutathione, which helps with dealing with the hydrogen peroxide that is needed to convert iodide to iodine. They could have low vitamin D, which helps modulate the immune system so it doesn't attack the thyroid. Or they could have, most importantly, they could have potentially low selenium, which is needed for this deiodinization between T3 to T4 or reverse T3. And so these are nutritional factors, either through the diet or supplementation that needs to be addressed, I mean, in my opinion, before just hopping right on medication. Because then there will be some other organ system that's going to be affected by not addressing these. Losartan, this is an angiotensin 2 receptor blocker, indicated for hypertension, diabetic nephropathy, heart failure. Side effects of this one, diarrhea, muscle cramps, dizziness, insomnia, nasal congestion. Hyperkalemia, be careful with this. You'll see potentially high potassium levels in people on angiotensin 2 receptor blockers. Lots of different impacts on our metabolic pathways. And so, I mean, basically anything that's associated with blood pressure regulation. So vasoconstriction, you're going to see alterations in that, alterations in contractility, oxidative stress potentially increased, endothelin, which is affecting blood vessels, vasopressin. So lots of different effects there from that. Nutrient depletion, CoQ10 potentially depleted from losartan. Drug-herb interactions. Again, because this is from CYP3A4, be careful with St. John's wort, which is an inducer, which will lower drug levels. And then grapefruit CYP3A4 inhibitor will increase levels. So be careful with those. Let me say, I really like St. John's wort, but I respect it and I use it very sparingly. It is a mild SSRI. It's a very potent antiviral too, but it interacts with many medications. So you have to be careful when someone uses it, but when it is indicated and when there's not other conflicting medications that they're on, it works really well. So I'm actually a big fan of it. Losartan, what's interesting, they found that it's actually good for our mitochondria. So it will have inhibition of NF-kappa beta, and it will be an activator of PGC1 alpha, which increases mitochondrial biogenesis, increasing uncoupling protein, which will basically increase mitochondrial production or browning of adipose tissue, and then TFAM, which increases mitochondrial biogenesis. So some of these medications are not, that bad in terms of how they could potentially favorably affect our metabolism. The question is, what is causing someone's, because it's recommended for blood pressure, what is causing someone's blood pressure? The counterpoint to that is by not addressing the originating causes, there could be other downstream consequences down the line. Omeprazole, this is a proton pump inhibitor indicated for GERD, peptic or gastric ulcers, heartburn, Zollinger-Ellison syndrome. Some of the side effects associated with this: stomach cramps, bloating, diarrhea, nausea, vomiting, nutrient depletions, huge impact of magnesium being depleted on this medication. And this will throw off many metabolic pathways. And so you're going to have an increase in free fatty acids, increase in obesity risk, increase in insulin resistance, increased muscle loss. You need magnesium to activate vitamin D, so you're going to see alterations there, which is going to contribute to the insulin resistance. Decrease adiponectin, which is an anti-inflammatory myokine. It's an anti-inflammatory hormone secreted from fat cells. If it's low, it's associated with metabolic consequences, so that's not good. You're going to see alterations of gut microbiota on proton pump inhibitors. So just lots of negative consequences with this, to be honest, just from the magnesium. But you're impairing your digestion and absorption in general being on a proton pump inhibitor. So basically many nutrients, B12, calcium, folic acid, iron, zinc, and even protein. If you don't have HCl, you're not going to be able to digest properly. Drug-herb interaction, St. John's wort, same thing, CYP3A4 inducer. So that's going to decrease the levels, and grapefruit is going to increase the levels. I mentioned the pathways that are impacted by this. Here's an interaction between two medications. People that are on proton pump inhibitors will have higher intracellular concentrations of metformin. So that's kind of interesting. There is some mechanism here behind how that's occurring. So it's just one thing to consider, how one medication is potentially altering levels of another. And so something else to consider there. Somebody has GERD. One of the questions is GERD caused by some other medication that they're on? Medications that have been associated with refractory GERD, statins, ACE inhibitors, basically all the ones I mentioned in this talk: statins, angiotensin converting enzyme inhibitors, SSRIs, calcium channel blockers, antiplatelet medications, antibiotics, iron, NSAIDs, theophylline, nitrates, PD, phosphodiesterase 5 inhibitors, ED medications, and diphosphonates. Pretty common medications, all have an association with increasing GERD. With GERD, again, this is another frustrating one within the realm of natural healing, because the question is, why does somebody have reflux? One of the first questions is, what foods are they eating, or what things are they drinking? There are lots of aggravating things for GERD. Citrus fruits, chocolate, mint, coffee and tea, spicy foods, tomatoes, fatty or fried foods, onions, carbonated beverages, and alcohol. So one of the first questions is, are they eating these? When are they eating them? I'll find not only are people eating these, they're eating them late. And then when they lie down, they get a bunch of reflux. So one question is, are they eating these? I think with GERD, it depends on where they're at with GERD. If there is a high degree of inflammation present, especially if they're on the verge of Barrett's esophagus, you want to decrease that inflammation. I am a big fan of demulcent herbs. So mucilaginous herbs, slippery elm, marshmallow, alginic acid. You'll see this in some supplements, which forms this like foam lipid layer to prevent the gastric contents from irritating the esophagus lining. And then even just some more gentle neutralizers of acid, cal, mag, potassium carbonates can help with this as well. One question: the stomach needs to sense there is acid to close the lower esophageal sphincter. So in some cases, people have acid coming up into their esophagus because there's low acid in their stomach. And so sometimes the simple solution for this is to add acid. So apple cider vinegar, 18-HCl, just adding acid to the stomach will help to close that lower esophageal sphincter so the acid doesn't come up. Also, you have to be relaxed. You need parasympathetic nervous system activity to close the LES. And so if somebody is stressed and they're on the go and they're rushing, blah, 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 and they've had their coffee and their chocolate, blah, 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 and they go and they eat, they're too stressed. Their lower esophageal sphincter is not going to close. And so what's the solution there? Just give them a proton pump inhibitor so they could be nutrient depleted? Nope, we have to do stress management. There is a high density of vitamin D receptors in the lower esophageal sphincter. So vitamin D deficiency could be contributing to GERD. One herb that I thought was really interesting is Salvia militarizea, also known as red sage. In studies, it will actually increase the tone of the lower esophageal sphincter, so it will help it close. That's another really cool thing to consider. Gabapentin, this is a voltage-gated calcium channel blocker, glutamic acid decarboxylase modulator, and NMDA receptor modulator. This is going to be working on our GABAergic system. Side effects, dizziness, sleepiness, tremors, dehydration. Make sure you take this supplement away from magnesium supplements because it will alter the absorption of it. Nutrient depletions, big vitamin K depleter. Something to consider there for gabapentin. Also depletes folic acid, carnitine, B12, and vitamin D. Drug-herb interactions, relaxing things typically, are things that work in the GABAergic system. Beer, GABA, kava, albizia, wine. These can all result in increased central nervous system depression. And the metabolite pathways mainly impacted by this are your GABAergic and glutamate pathways. And so here we have glutamate. We have glutamine, which gets converted to glutamate, which gets converted to GABA, which GABA transaminase will convert it into this intermediate succinate semialdehyde. The glutamate itself will activate these excitatory glutamatergic neurons, and gabapentin will inhibit this process. There are consequences. So again, it's calcium channel blocker and works on the gabaergic system. There's consequences of using medications that are voltage-gated calcium channel inhibitors, which could lead to potentially intracellular calcium dysregulation. So what could happen is you could have effects on the bone, which you could affect bone mass, biomechanical strength, on muscles. Affecting voltage-gated calcium channels can affect muscle cell differentiation, muscle regeneration in response to injury, chondrogenic differentiated chondrocytes. You're going to affect these processes. So another tidbit is, what other things can affect voltage-gated calcium channels? Voltage. These are electrical. These calcium channels are activated by electrical signals. If you look up studies, if you look at the impact of EMF exposure, different types of EMF exposures, you can activate voltage-gated calcium channels and you can depolarize them with certain frequencies of EMFs. This is where, are people just crazy if they are exposed to EMFs? Is there potentially something in their environment that is also affecting this? I have a theory that maybe people that respond well to gabapentin, which inhibits this, it's because it's overactive from other things. So something to consider there. I know this isn't in the top 10 medications, but it's a popular one. So I wanted just to cover this briefly. Semaglutide is a glucagon-like peptide receptor agonist. This increases insulin secretion, decreases glucagon. Side effects from this associated with GI distress, nausea, vomiting, constipation, stomach pain, headache, fatigue, and has even been associated with some rare cancers, unfortunately. Nutrient depletions. So in theory, you could be deficient in CoQ10, and what has been well studied, sort of like the proton pump inhibitors, B12, vitamin D, calcium, iron, protein, and zinc, potentially depleted there. Drug-herb interactions, so anything that is helping or assisting with this process of insulin secretion, glucagon, glucose regulation. So glucose-lowering herbs, ginseng, anise, ashwagandha, banaba. Be careful there. And metabolite pathways, because we're impacting metabolism and metabolic rate and these things, it's going to be many different types of metabolite pathways. Glycolysis, gluconeogenesis, energy metabolism, fatty acid synthesis, oxidation can be impacted. There are many, when you're impacting glucagon, there are many different things that are occurring in the body. You're going to be affecting skeletal muscles, your central nervous system, especially you're going to increase satiety. Going to have effects on the kidney. You're going to be affecting adipose tissue, increasing uptake, theoretically, of plasma glucose and triglycerides, decreasing fatty acid synthesis, increasing myocardial performance. You're going to be upregulating the AMPK, mTOR pathway. So lots of good benefits. The question is this by sidestepping? A lot of people say this is like insulin. Like by administering insulin, there are lots of good benefits up front, but the consequences that long term could be potentially detrimental. And to what degree are we activating these glucagon-like peptide receptors? And so there are profound benefits on metabolism from glucagon-like peptides, but there's some also, and even mechanically too. Glucagon will slow our gastric transit. So a lot of these side effects are from this slowed transit, and it also depends on the glucagon-like peptide medication. Semaglutide is one of them. Tirzepatide apparently has less side effect profile. But only if there was something else, I'm going to get back to the slide, only if there's something else we could do to affect glucagon-like peptide. Actually, there is. And so there's been studies that have looked at resistant starch's impact on glucagon-like peptide, and it's actually had a more profound effect than glucagon-like peptide 1 medications. So sources of resistant starch, I'm actually not a fan of these, but cooked and cooled potatoes, cooked and cooled rice, green bananas, good sources of resistant starch, assuming your gut can tolerate it. Butyrate itself, glucagon-like peptide agonist, olive oil, cinnamon, raw honey, chlorogenic acid from coffee or green tea, berberine, resveratrol, ginseng, glutamine, bitter melon, quercetin, all glucagon-like peptide agonists. You could look at the metabolome. This study was actually done in mice, so they haven't really looked at the metabolome or metabolites individual from semaglutide. But as expected, you'll see many different changes in metabolic pathways. You'll see changes in choline metabolism, purine metabolism, changes in caffeine metabolism, green secretion. This is on blood pressure. So some good beneficial changes, at least in mice. I would like to see this replicated in humans. All right, in summary. So likely you're going to encounter somebody with medications in your practice when performing metabolomics. If doing metabolite testing, make sure to account for the impacts of medications on metabolite pathways. Consider using, so when you're looking at medications and different dietary things and different supplements, how do you know how these are all affecting one another? This is where artificial intelligence can help to account for the impacts of different medications or supplements on different metabolic pathways. Make sure you're working within your scope. Don't lump some medications if it's not within your scope. Address potential pathway intervention or potential pathway perturbations with targeted interventions. And this is a general rule. Don't recommend supplements that are going to decrease medication absorption. You're just going to piss off their physicians. Psyllium, guargone, charcoal, pectin, casein, chitosan. Just be careful with these. Some resources, it is essential Natural Medicines, the database Natural Medicines, NatMed Pro. They have everything. They have an effectiveness checker, a drug nutrient depletion checker, interaction, lactation, breastfeeding checker, adverse effects profile. So I would highly recommend this resource. You want some free resources, mitavin.com helps identify drug nutrient depletions. Pure Encapsulations has a database as well. Same thing with Linus Pauling Institute, which I really love Linus Pauling Institute. Drug interactions, there's a bunch of them. Drug bank's one option. If you want to look at pathways specifically for breakdown products, there's Metabolomics, which is probably a bit complex for most people. It's more of a science-driven database. You could look at different metabolite pathways for drugs as well. Pharmacogenomics, PharmGKB is essentially the gold standard. And then if you want a website as a repository for all these links, just what exists, pathbank.org is a good resource to look at. So, as I mentioned, I am an employee at Ethereum, and you can meet with me to discuss this topic or any topics within the realm of metabolomics or anything in general by going here. And so, Amy, if you're still there, someone had a storm. Okay. So yeah, I will put this link in the chat. And otherwise, I will thank you so much for attending. Please feel free to meet with me to discuss this. Thank you for putting them there, Amy. Yeah, so you can click on that theory.me/train. You can talk with me about the metabolomics. We're also adding a microbiome test. I think we should probably have a webinar at some point of drugs impacting the metabolome, no, the microbiome, because that'll be that's another big topic because it will impact our drug metabolism, especially antibiotics. That's a big one. But anyway, all right. So there's the sign up link. And with that, any questions? I know that was a lot. I don't know how familiar y'all are with using medications in practice. And obviously, I just covered about 11, but there's a lot. I was thinking psychotic medications would be another huge one. We'd have to dedicate a whole webinar to it. That's fairly complex. Antibiotics would be another one. Absolutely, Lori. Thank you so much for attending. All right. If no one else has any other questions, I will end the session. I mean, and we are over time, but. All right, everyone. Thank you for attending. We may be doing a case study next Friday, so stay tuned for that. Otherwise, yes. Yep. Thank you so much, Amy. Yes, this webinar will be uploaded to our YouTube channel for everyone's viewing pleasure. Absolutely. All right, everyone. Take care. Enjoy your weekend. Bye-bye.